at this webinar, which we hope will provide you with an overview for excellent speakers from around the UK around innovations in home ventilation, particularly with reference to the COVID-19 pandemic. We're going to try to get straight into the talk rather than having too much introduction, but I'll just say a couple of words about our first speaker, Milan Savanni. He's a professor of medicine at Nottingham and the lead for the acute respiratory service there. He's obviously an expert around both home ventilation and some of the problems around non-invasive ventilation and respiratory pathogens. And so I'd be, grateful for him to take us through an update in the BTS guidelines on infection control for the delivery of non-invasive ventilation. Milan, thanks very much.
Right. Afternoon. Thanks for that introduction, and you promoted me to a full professor, so thank you for that. Right, we will start with the talk. It's NIV and infection control during COVID pandemic is what I'll be discussing. I'm one of the chest doctors from Nottingham, as Paddy mentioned. Right, so I'll try and cover COVID transmission. Is it a droplet or aerosol or both? Is NIV an AGP? It may sound like a rhetorical question. What are the risks associated with NIV, both to users and caregivers? The measures we can take, mitigating measures to reduce the risk, how to manage NIV admissions, NIV in community, and the important question of ongoing shielding. So right at the start, WHO mentioned that COVID is a droplet infection. It spreads through droplet and fomite, coughing and sneezing and close contact. However, we within the respiratory community were very worried about use of NIV because it's thought to be an AGP. We know that hand washing can reduce COVID spread by about 16%, but what it means is there's a vast major 84% of the spread. There are other ways that we need to work on. More importantly, we also know that there have been multiple clusters and outbreaks of COVID with a 20-to-1 ratio, 20 outbreaks indoors versus 1 outdoors, and these are in hospitals, care facilities, bars, and these have been often by asymptomatic spreaders. There is also the JAMA report where there was a transmission in a bus. The bus was such that air was being recirculated, and didn't matter how far you sat from the index case, you still got this infection. So this again highlights that there is probably an aerosol spread of COVID. More importantly, viral RNA has been detected in air samples for, this is COVID viral RNA detected in air samples from ICU. And when you have got enclosed spaces and prolonged exposure and inadequate ventilation, that's where the COVID risk has been highest. So there has been more and more and sort of acknowledgement really that COVID transmits via aerosol as well as droplet. This is a small study. This is a study in about 600 patients from Italy. They looked at CPAP delivery in COVID patients outside ICU, and what they found is that the infection rate was 11.4%, again going up to 13.8% in nurses. So this compares to just 3.8% infection rate in other hospital workers who were not involved in COVID CPAP. So again, highlighting the risk of infection transmission. So at this point, I would like to ask participants, have you had an outbreak of COVID in your hospital? Yes or no? If you had it, was it on the respiratory ward, but where no NIV was given, or a respiratory ward where NIV CPAP was given, or a non-respiratory ward? And if you can scroll down a little, you can see the third question in full. In your hospital, acute NIV during pandemic, where was it delivered without problems? Was there a reluctance to deliver but no harm to patients, or maybe a bit of delay with potential harm? So, as we can see on the screen, so about 94% of you have said that yes, there was outbreak in hospital, and it was significantly 55% of those outbreaks were on non-respiratory ward. Again, highlighting this issue really, and but I'm glad to see that in about 60% of cases, NIV delivery, acute NIV, was done without any problems. So thank you for that. So NIV as AGP, we will look at patient factors, equipment, and we'll also look at ventilation of the room that in which the NIV is delivered. So we know that shielding works. We recently did a survey of 600 patients on home mechanical ventilation. This is Nottingham and Newcastle. 87% were strictly adhering to shielding. 5% reported COVID-like symptoms, but only 2 tested positive. None of these needed a hospital admission. We have also seen a dramatic reduction in acute NIV admissions as well. So if we know that somebody has been shielding, then the risk that they would be COVID positive would be less. If their family have been shielding or haven't been in any contact with others with symptoms, then again, that goes even further down. And if there is alternative diagnosis, for example, somebody is coming with, they're poorly because of, say, cellulitis or decay, then the risk of COVID is further less. I think rapid COVID test is certainly proving to be a great help in our setups. At this point, I would like to sort of share with you a study that was done by Anita Simmons. I hope, Anita, what I mentioned here is correct. Please, if there are any errors, please correct me. So this study was done following the SARS epidemic, when Anita and her team, they looked at NIV delivery, and what they found is that when NIV was delivered via a vented mask, it led to large droplets. The similar finding was seen with physiotherapy as well. And when NIV actually was delivered via non-vented mask, then the droplet production was mitigated. And this was seen only in people who were coryzal symptoms or who had diagnosed infection, but this was not seen in healthy volunteers. That's the other important thing to remember. And they used AeroTrack device as a particle counter, and these particles that were generated were about 10 microns. Following this, we have used a non-vented mask during the current epidemic when we have been trying to deliver an IV. And I would like to highlight a couple of things here. Non-vented masks need to have an anti-asphyxia valve. Otherwise, if there is any cessation of an IV due to some problem, then the patient will suffer. The second thing I wanted to highlight is the slide in between. There is a risk that people will mix together the non-vented mask with a vented circuit and a vented mask with a non-vented circuit. It can become a jumble as shows in the picture, and there is a risk that somebody can go home with a non-vented mask and a non-vented circuit. And although it is difficult to put these two together, if something can be done, it will be done with a potential risk of CO2 rebreathing. The other issue with using non-vented mask is most of the times when we do home NIV, we are these days using vented mask, except for those occasions when we use IPPV. So patients suddenly have to use a mask that they are not used to, they are not comfortable with that. So this can be an issue. So particularly when after an acute episode, we are sending somebody home, it is important that we check their circuit and make sure that there isn't any error. going further into aerosol, we know that non-vented mask help. Well, what happens with nasal? What happens with nasal masks? This is a nice study by Hu et al. So this was done in a patient simulator. What they did was use nasal pillows, and what we can see here is that with increasing CPAP pressure, there was increasing dispersion of smoke that they used in this patient simulator. But also the other interesting thing is, when they use the lung model of a severely ill person, which are the red dots, then the dispersion distance goes down. So the stiffer your lungs become, the less further you disperse air particles. Similarly, from the same study, we can also see that when we use high flow oxygen at 60 per minute, it goes up to this exhaled air dispersion goes up to 172 millimeters, which is 17 centimeters. And with 30 liters per minute, it goes up to it goes up to 60 or maybe up to 130 if you have got normal lungs. So between 13 to 17 centimeters is where you will see the plume associated with high flow nasal cannula. What happens with NIV? Well, same team, again, Hu et al., they had looked at this using NIV with face mask and pressure of 10/4 on left-hand side and 18/4 on right-hand side. And as you expected, with the higher pressure, you can see higher plume with the probability of aerosol going up to 50 centimeters from patient. Important thing to remember is this was done in a room which was not at all ventilated. This is the important thing to remember. Similarly, when high flow was used in patients, when they were coughing, the coughing spit actually went from, on average, of about 2.5 meters to almost 3 meters. So having high flow and coughing with high flow increases the dispersal distance. However, let us look at this study. This is a really important study recently published in the Blue Journal. This is a rather busy slide. On the y-axis, you have got the number of particles, whereas on the x-axis, we have got a range of oxygen delivery devices with room air on the left-hand side and non-invasive positive pressure 20/10 on the right, with high flow cannula in between, which are in blue. And what we can see is that the number of particles are sort of highest, although it may not be statistically significant, when you're breathing room air and without the face, without face being covered. And actually the particles go down as one uses high flow and maybe come up with NIV. However, the most important thing to remember here is that this experiment was done in a negative pressure room with 15 air changes per hour and an air scrubber in the room. So the take-home message, I think, from this study is that you can only say that in such a well-controlled room, so negative pressure, frequent air changes, air scrubber, doesn't matter what you use, it's going to sort out the aerosol. Same authors, same study, they then looked at the particle size, and what this shows is that, again, irrespective of the method of oxygen delivery, particle size is between 1 to 2 microns. Is it important? Yes, it is. And why? The reason for this is that its particle size up to 5 microns, which we breathe deeply, and it gets deposited in not only distal airways but alveoli, and that's where the ACE receptors are. And these ACE receptors that the COVID virus attaches to. So this is something important, that the aerosol generated from NIV and high flow is actually going to be deposited in distal airways. Further, a couple of studies, both here, one study looking at high flow nasal oxygen on the left with blue pictures, the other on the right from the recent edition of Thorax, where they have used mask to look at coughing and sneezing. And basically, whether we are using high flow, high velocity nasal insufflation, or we are looking at coughing and sneezing, use of mask, particularly 2-layer cloth covering, significantly reduces this. So mask is, although it's a fairly straightforward thing, it is important in minimizing aerosol and droplet. This brings us to ventilation and aerosol. Now, when we sneeze is one of the single most droplet producing act. So from 40,000 to 2 million droplets from a single sneeze, compared to around 100,000 from a cough and 3,000 from speaking loudly. So even act of loud speaking can generate aerosol, but sneezing is of a completely different magnitude. What we also know is 86 hours of quiet breathing with high flow nasal oxygen would generate same amount of sort of droplet aerosol, which would be generated by 1 minute of coughing. So although we worry a lot about AGP nature of an IV, I think we really have to focus on coughing and sneezing as well. How can we manage that? How can we mitigate that? There was a nice study from Hong Kong, actually. So what they did was they looked at, this is following the Sars epidemic, they looked at large ward with large ventilation windows as opposed to small ventilation windows. And when you had the larger ventilation windows, the rate of infection or transmission within the ward was down. And natural ventilation is really effective. If you have got cross ventilation, then you get 69 air changes per hour, 69 air changes. If you have got one-sided windows, then even that is not bad. It gives you 18 air changes. Ideal recommendation is 12 air changes, and 6 air changes are minimum. But we know that a number of our sort of hospitals and wards are old and don't necessarily have the facility for these air changes. In fact, we know that sometimes air is just being recirculated, and that's one of the worst things. So I think if we can say one thing to our patients when they are using either in hospital or more importantly at home, one thing we can say to them is, if you open your windows, then any aerosol that is going to be produced is going to be washed out very quickly. Within an hour, that room's volume of air is going to be changed 69 times. So any particles that are going to be there are going to be diluted tremendously. So taking into these considerations, as we have already seen, the patient factor, the mask and cervic factor, and the ventilation issues. When I say ventilation, it is the ventilation of the room. We have come up with this BTS guidance, dividing patients into low and high risk, and then coming up with the recommendations about isolation and circuit and PPE. So if you've got low risk, and ideally, you should have been isolating, plus you would have had a rapid negative COVID test, then you don't need isolation, and we can look at using standard circuit. If there is any doubt, it is better to err on side of caution. We have in NUH sort of, we have been working on similar principles, but what we did is we not only just did that, but also looked at where these patients can be admitted, because we are a cross-site hospital, and often patients will come out of hours and get admitted to surgery, for example, for some operation, and they are on CPAP or an IV. So what we had added as an extra level 2, that is where these patients can be admitted in and out of hours and where they can get help. We will need to change or we are in the process of changing the right-hand column to say that patients can use machine and mask if they are not suspected of COVID and are COVID negative by swab. Right, so this brings us to mitigating measures. How can we really control the aerosol generation of an IV, or for that matter, any procedure? And this is a really good study. This is from a preprint journal. It's not yet peer reviewed, so to be taken with a pinch of caution. And this is on mathematical modeling. That's the other important caveat. Saying that, so what we can say is A, B, C, D, E. A is with, which is the red bar. So just with passive ventilation, we can reduce the transmission compared to no ventilation. But the moment we add active ventilation, this is when I say active ventilation, again, ventilating the room, changing the air 12 times an hour. That again drops down dramatically. You add active ventilation and facial mask, face mask, that again further reduces it. And if you are to add a HEPA filter, then that almost dramatically reduces the aerosol and any risk of transmission. So I think things to look for are actively ventilating your room where you are having an IV, either in hospital or at home, using a face mask when possible. And one sort of maybe crazy idea is whether while somebody is having a nasal IV, whether they can cover their face using a face mask, surgical face mask. And similarly, other measures, particularly in hospital, using HEPA filters, and we are using HEPA filters in our unit. That's really helpful. So coming back, NIV during pandemic, as we know, there are risks to healthcare workers, including COVID transmission, importantly, risk to patient as well. You can get COVID from carers. You can get COVID whilst you're in hospital, even though you came without any COVID infection to begin with. There can be delay in NIV initiation. There can be incorrect circuit. And there are significant servicing issues. As we know, some hospitals are doing servicing by visiting patients at home and doing servicing there in PPE, whilst others are asking their patients to bring their ventilator, put it on a bench for 72 hours and swap them and swap their ventilator for a new one. And there is a risk there that patients can get wrong settings. And if they get wrong settings, that can have untoward consequences. So those things need to be controlled rather. Then there is the risk to family, of course, infection rate risk, but also extra workload. A lot of our families, what they have done is they have said during this epidemic is that, you know what, we will use carers for other things. We will do the personal care to minimize that risk. So that's an extra workload. They have been changing their work practices to try and minimize exposure, vulnerable, often, spouses or children. And then they have also been struggling to sort of bring kids to and fro, and getting hold of people for various consumables has been a significant problem. We briefly have discussed already NIV and COVID transmission. So outbreaks on ward can be patient to patient, patient to staff, and staff to patient. We have seen 11% of healthcare workers affected when COVID CPAP was done outside ICU. In our hospital, one of our patients, they came in, treated for NIV, waiting to go home due to social circumstances. It took rather long to get things sorted. And 3 weeks into their admission, the ward they were on had an outbreak, and they got it as well. Thankfully, they were okay, but just highlighting that it's not just what our NIV patients or HMV patients will give to others. It is also that others, there are carers or us, we can give COVID to them. And that's an important point to think of. So I think PPE, correct mask and circuit, and room ventilation is really important. I would like to ask here to the audience, from your HMV cohort, how many patients, if any, had COVID? Are you aware that COVID transmission has happened from HMV patients to their carers? So about 40% with no infections and 1 to 5, but I can see that about, in about 20% of those reported, we have had more than 5 patients, and in few cases, more than 10 patients having COVID. So, and again, in most cases, there wasn't transmission from our HMV patients to carers, which would suggest that these patients actually got it from their carers. In community, our patients are currently stuck at home. There is significant anxiety, about the risk of transmission at the schools and colleges they attend. There has been talk of weekly testing to reduce risk of transmission, which is a PhD project. This is an ongoing thing, as you know. But there are some issues around this. So who will manage quality control? What will be the turnaround time for these tests? What will be the compliance? In the meantime, I think we have to remember that, as we just saw in that survey, that in most cases, our patients got infection from their carers. So really important that the carers and friends and family around them use surgical masks. They use hand hygiene. There is significant cross ventilation of the room to minimize this risk. There are other issues around the servicing of equipment for the consumables. I think there was somebody complaining on BBC about lack of HME, which is again a really important thing. And then, of course, what I haven't really touched at all is tracheostomy care whilst out and about, because I think that's a completely separate topic in itself and needs to be dealt properly. But that is an important issue I would like to highlight. So I would like to conclude by saying that NIV can lead to both droplets, as Anita Simmons' study had shown, as well as aerosol. And we know that SARS can spread via both these methods, or we know that droplet control can be used using a mask, hand washing, and social distancing. Aerosol a surgical mask covering the nasal NIV, or surgical mask during physio. Most important. And then I think the real question, what do they do now? Some of them would say, you know what, one of my patients, I will only come out when the clean comes out. That, you know what, year two, and I would not want to be cooked up in my house. So how do we manage those two different populations needs to be thought through carefully. And provided we think of all these factors, I'm sure we can do a patient-based and individualized approach to optimize both the NIV treatment as well as quality of life for our patients. Thank you.
It's a great deal of data to cover, and you did so excellently. There were a couple of questions in the chat, and there's a limited time, but hopefully, if I could ask you the first question. Already, I suppose it's a comment from one of the attendees. He was saying that there was significant reluctance to use NIV in their institution, and it was only used in negative pressure side rooms. I mean, what's your experience around using NIV? I'm assuming in Nottingham you're not using it exclusively in negative pressure side rooms. So what's your experience of using it outside of that environment? And are you able to provide some reassurance?
So for the so we have had great reluctance from our ED colleagues to use NIV. So we have designed a completely new pathway so that patients will directly come to us. Till we had the rapid test available, we were actually, and we had thankfully enough real estate pressure till we knew that patient was COVID. We could confirm that they were COVID negative. Once over the acute phase, we have been able to move them outside of the negative pressure room, but into a side room. So yes, it can be done in a side room, but again, the key thing is they need to be negative. They need to be, the ventilation in that needs to be appropriate. And more importantly, in that scenario, nobody else is going to give COVID to them. That's also an important consideration.
I think picking up on that point, we probably just have time for one final question from the chat. So one of the delegates has asked around the risk of long-term ventilated patients using the unfiltered, vented masks in the community, and what's the risks of that, and also if they then come into hospital, test negative initially at hospital, given the high prevalence in the community and in healthcare workers, what's the chance of them picking up COVID in hospital and actually then having an active open AGP and spreading that infection? Are you aware of any data around that?
So although I was not aware of big data, that has been the nightmare scenario that's keeping all of us awake, I suspect. The key thing is you really have to delve deeper into your patients and lots of history taking. If they have been shielding, if they haven't been in typical, no lymphopenia and so on, then your negative test in context of all those gives you extra reassurance. If you are very worried, you could look at twice. Occasionally, I know that we have had 2 tests positive, but that's where, or a second test positive, that's where actually you had the pre-test probability high. So you didn't really believe the negative test. Whereas when there is low clinical probability and first test negative, the risk of second test coming positive is very low. I don't know if that answers the question.
That's excellent, Milan. I think, you're right. We've had a number of patients where we had a high clinical suspicion and we weren't reassured by an initial negative swab, and I think that's an important message. We haven't seen it significantly yet, but I am worried that, when the prevalence becomes high, that we'll have patients with atypical syndromes and we've all seen patients with relatively mild illnesses, even if they've got respiratory disease, or even neuropsychiatric presentations of COVID infection. And I think that atypical presentation that may be negative will be a problem, but I think we'll just all have to face that.
I couldn't agree more. But again, if we do an IV in a well-ventilated room, what I have learned from this is that even if you are putting out virus, if we are washing it away then and using PP, then the risk of that is low. If you are churning out virus, whether via NIV or via just talking, because most of the transmissions have been in asymptomatic people who have not been coughing, then that's where the risk is. So I think wherever you do your NIV, please ensure that it's really well ventilated room. It doesn't have to be negative pressure, but open the windows if you can. Don't make patient hypothermic, but really ventilate it as well as you can. Yeah,
I think, as you say, that opening the windows probably was easier in May than it will be in November and December. Totally. We'll certainly do our best. Milan, thanks again for joining us and giving us an insight that was incredibly helpful. I'd like to move on to the next speaker, Michelle Chatwood, who's a consultant physiotherapist at the Royal Brompton, and many of you will be familiar with her published work in the areas of mechanical insufflation, exsufflation, and she's going to provide us with an update on how we manage secretions in patients with neuromuscular disease. So Michelle, thank you very much for joining us and giving us this talk.
Thank you so much, Paddy. I hope you can all hear me and you've got my slides. So I was thinking about how to compile this presentation for you. And I think the first way to look at it was to base it around the questions that we were faced with initially at the start of the pandemic. From the clinical team, it was with regards to what services we should provide and who we should provide them to. And then I'm just having a technical problem here. Excuse me 1 minute. That's it. And with regards to the patients, it was the fact that they didn't want to come to the hospital, that they didn't really want to have healthcare professionals come and visit them. With regards to carers and care providers, the questions that we had were around what airway clearance techniques are at higher risk to the carers. Should patients actually stop doing airway clearance techniques was one of the questions that was often posed to us. And how do we minimise the risk to themselves? So our patients, as we've already heard from Milan, were technically asked to shield at the start of the pandemic, but with the new guidance as the 5th of the 11th, our patients with Parkinson's disease and motor neurone disease and multiple sclerosis have been pretty much a little bit downgraded to clinically vulnerable. And if we look at the clinically extremely vulnerable patients, whereas those with respiratory conditions, including cystic fibrosis, severe asthma, and severe COPD are mentioned, those with neuromuscular disorders are not. Now, if they seem to have been missed off the list, we can ask the GPs to add them to the list. But we do find that our patient group at times falls a little bit between a pillow and a post. With regards to physiotherapy, the current guidance is that physiotherapy is a key service and provision should continue at the moment. I would slightly disagree and say that respiratory physiotherapy, in my opinion, is essential. But what we are going to find is that with the increasing number of COVID patients, this will put pressure on the provision of respiratory physiotherapy services for patients with neuromuscular diseases. And so what we've had to do and what we will continue to need to do is to stratify and triage the need for treatment. We will need to maximise the delivery of treatment, and we will need to target the individuals that will benefit the most. With regards to secretion management, we have our toolbox, and the techniques that I'm talking about today are those predominantly that include manual techniques, percussion and shaking, oscillatory devices, for example, the vest or intrapulmonary percussive ventilation, and manually assisted cough, breath stacking and insufflation techniques, and mechanical insufflation-exsufflation devices. You'll notice that some of the techniques are highlighted in red and some of the techniques are highlighted in green. Red techniques are those where aerosol generation will occur, and green are those that are deemed to be non-aerosol generating. Hospitals will have their own local policies, and these are the excellent local guidelines for physiotherapy with regards to aerosol generating procedures at the Brompton Hospital. And what is significantly important is that we need to assess our patient and their risk once we are performing a technique, and therefore wear appropriate PPE. And this has already been covered to some degree in the earlier presentation, but it very much depends on where you're admitting people to, whether they're on a low risk pathway or a medium risk pathway. And basically the difference is whether they've actually managed to have a confirmed COVID test and that they've been isolating within that period. For us, the majority of patients that we see are being seen on a medium risk pathway because we are not able to get them to isolate and have a COVID test for the period of time for them to become in for a day case on a low risk pathway. Like Milan, our experience is that we've had very few cases of patients presenting with COVID-19 with neuromuscular diseases, and this is because they have shielded so well. They've literally hunkered down since the start of March, and for those that I've reviewed via video consultation, they still haven't been out to this day. They've asked that their carers be regular carers and that they're not mixing between other households. And they've also done other management strategies to maintain or utilise family members to provide their care. But what we've had to do is we've had to change our patient management programme. It used to be easy to bring a patient up and teach them and assess their cough. But now we've moved to virtual appointments. And where possible, we want to virtually review the patient. And by this, I mean via a video consultation rather than a telephone consultation. If the patient reports that they have no issues with airway clearance techniques or cough, then obviously we just need to follow them up and we don't need to action anything further. If the patient has issues with airway clearance or cough, then we need to look at whether they're a current patient or a new patient. And what we've found is, and I will talk about this in subsequent slides, is that it can be quite easy to optimize these patients remotely. But if this does fail, we need to consider whether they would come up to hospital or accept a community review. If the patient is a new patient and they have severe bulbar dysfunction, we know that often there is a high chance that any airway clearance technique and cough augmentation technique will be ineffective. And we've stratified these to provide oral suction in order to clear secretions from the back of their throat. If they have no to moderate bulbar dysfunction and an ineffective cough that we will have assessed via video link, then we have to deem whether we can bring them up to the hospital on in our situation, a medium risk pathway, or if we can provide a community review via our paediatric and adult outreach services. So what can we do? Looking at virtual reviews, can we review the patient's cough remotely? I think a key thing is that we've learned, even in clinics, when we've had face-to-face consultations, is if we ask the patient if their cough is effective and they answer yes, the chances are it will be. If they say no, or that they have difficulties, then what we need to do is assess their cough. And we can do this by look, listen, and E. So we can look to see if we see a rise and fall of the chest and the abdomen. Do we see paradox? Do we actually see a good inspiratory capacity? We can listen to the quality of the cough, and we can have an idea about whether there is glottic closure followed by rapid glottic opening. And if we suspect there isn't, we can ask the patients to phonate E, E, E to determine the degree of bulbar dysfunction. Now, the chances are that we'll probably have a preconceived idea about this just by listening to the way that they talk. And if objective measurements are needed, we can send out a peak flow meter and a mask. If we're worried about people coughing, we can utilise a filter to filter expiratory flows. And one novel concept is that if someone is coughing, we can utilise a face shield. So not only as healthcare professionals or carers we are wearing a face shield, but we can also ask the patient to wear a face shield to prevent spatter towards the healthcare worker. And it's already been talked about adding in a face mask in this situation. We can also look to see what happens when the patients cough. So in this situation, you can see that the patient coughs well and she is able to clear secretions into her mouth. Conversely, this patient,
deep breath in and cough.
You can hear that the audibility is a lot less, and this patient is unable to clear their cough effectively by themselves.
If you could have a cough for me.
Although this patient sounds fairly strong, there may be an indication that glottic function is starting to become a problem. So you can ask them to phonate E, 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 E.
E, 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 E.
And if you need to take a measurement of peak cough flow, this can be done also by sending out the peak flow meter and asking the patient to do it with instructions.
Breath in, pop it in your face, cough hard, lovely. What was the score? 170.
And it's important to remember that you can also ascertain whether someone is improving with a technique with regards to their peak cough flow.
Okay, fantastic. And now if you could glossopharyngeal. Fantastic, and show me that.
So this patient has performed glossopharyngeal breathing, and you can see that their cough strength has significantly increased. But conversely, you can do this with a manually assisted cough, or you can do it with a maximum insufflation capacity via a lung volume recruitment bag. Once you know the individual's peak cough flow, you can ascertain what technique that you need to use. And we've got these guidelines that were prepared via the ENMC workshop to help you with this. The values are for adults or anyone over the age of 12 if there's anyone from the paediatric population watching this webinar. But if I summarise it, the way that I would look at it is that for those patients that have a slightly deranged cough, you would perform a manually assisted cough. For those that are slightly weaker, you would teach them breath stacking via a lung volume recruitment bag. And then you can combine the techniques and use mechanical insufflation exsufflation in those patients that are significantly weak, or if their peak cough flow is definitely under 160 litres per minute. And this has implications because, as I said at the start of my presentation, if you're looking at a manually assisted cough and a lung volume recruitment bag, these are not deemed to be aerosol generating procedures, and that has implications over PPE, but also about how many patients you can get it through the room should you need to bring them into the hospital environment. And as I've said, if someone has severe bulbar impairment, then what you would do is move towards using or providing oral suction in this patient group. With regards to treatment optimization, what can we do? Well, we can optimize these patients' techniques and settings remotely. You can review techniques via video link and optimize with the carers and their feedback. It may be that you actually want to look at compliance or flow or cough strength via the mechanical insufflation exsufflation devices, and you can ask for data to be sent back via smart cards or look at compliance on download. And if we do fail, then we need to have a strategy of what we're going to do. Are we going to ask the patient to come into the hospital, or are we going to utilise our outreach services? I actually find that reviewing what the patient does at home can actually be more insightful than them coming into the hospital, because you're seeing exactly what's happening with the carers, how they're placing their hand and how they're using the device. And you can ask them and slightly suggest changes, and the patient can give you feedback. The key thing is not to suboptimally treat. So in some instances, I've had questions about whether we should turn down pressures to prevent as-far aerosolization. Patients need to continue their airway clearance regimes, and they need to have optimal settings. Otherwise, we're going to find that these patients are being admitted to the hospital with an acute respiratory tract infection, which is unrelated to COVID and will put them at risk of potentially picking up something within the hospital. So I've already highlighted that you can ask, if you're assessing cough, the patient to wear a face shield or to put a face covering on if you're just listening to the audibility. But if you're teaching a manually assisted cough, this can protect the carer or the healthcare worker further than them wearing their own PPE. If you're looking at performing manual techniques and doing assisted coughs without using mechanical insufflation exsufflation, you can look at changing the mask to a total face mask, which again provides a barrier between the patient and the healthcare worker. If we're looking at, do we need to protect the machine? So are we using a machine between patients? What we can do is consider double filtering if we have filters available, placing one filter at the machine end to protect the machine and the other filter at the mask end to filter the expiratory flow. What you also need to do is you need to maintain, if you're using mechanical insufflation exsufflation, the mask in situ for the period of treatment. So you put the mask on, you ensure that the seal is tight, you turn the device on, you allow it to cycle for however many cycles it would normally do. If it stops automatically, fine, let it stop, At that point, you take the mask off and clear any secretions from the mouth. Or if normally you would let it cycle until the patient gives you a signal, rather than taking the mask off and dealing with the secretions, which is what we would do normally, you would stop the machine and then clear it, leaving the mask on till the machine has stopped. If we're wondering what's going on and we have the capacity, we can look at the the mechanical insufflation exhalation devices downloads to look at whether the peak cough flow is changing, whether the patient is actually reaching the set pressures, because often you'll find that the mask may not be put on properly and that there's a significant amount of leak. And have the volumes changed? Do we need to adjust our settings because the patient is getting weaker? We can look at compliance to see how much the mechanical insufflation exhalation devices have been using. And in this picture, you can see that the patient is using the device stably on one session on average per day, but something has changed and they're now needing to use it for longer and for far more sessions a day. What do we need to do? Do we need to review the patient in the hospital environment, or do we need to ask our outreach team to go out and review? We need to think about other areas. For example, schooling. We need to get these children back to school. There's been a great support for home working for the neuromuscular patients, but schooling has already been highlighted. So if they do need to carry out airway clearance techniques or cough augmentation techniques, can we change what they do? Can we find an area that has good ventilation? Can we adapt the regime? Often you'll find that people have been nebulizing for a number of years, but can we change this to giving for example, bronchodilator via a spacer? Do they need to continue to have hypertonic saline? Can we just fine-tune what we're doing? And we also need to look at how we can train teams to look after these patients. Does it need to be face-to-face or does it need to be virtual? If we have a patient that's suspected of COVID, of course we want them to have a test. In the home, as we've already heard, we should encourage opening of windows and maintain this post-treatment. Ensure that appropriate PPE is available for carers. We need to minimise the amount of carers that are treating the patient. And we also need to ensure that we have provided techniques to minimise droplet dispersion and that we've put a physiotherapy escalation plan in place. What not to do? That was one of the things. Well, continuing as we were before and not adapting our services to the current situation. We shouldn't not offer an airway clearance service, and we shouldn't tell patients to stop doing what they're doing. We need to utilise outreach services more and use joint consultation. So if a healthcare team is going to visit the patient, can we join them via a Teams meeting or a video conference? We shouldn't trial devices in patients that we know will be unsuccessful. And we should not provide the wrong advice regarding the level of PPE required. So I think this is an ideal time to embrace the opportunity to change our working practice for the better. I think we can utilise video reviews to triage, identify patients and treatment regimes. It can be used to optimise settings remotely, but a key service is now looking at how much can we do in the hospital, but more importantly, how much can we do in the home environment. And we need to use this time to really see if the airway clearance regime that the patient is using is working. And if it's not to keep on going, we need to change it. And also consider simplification of simplification of regimes. So I'd like to thank you for listening, and I'd like to thank our amazing outreach team, Debbie, Steve, Caroline and Ruth.
Thanks, Michelle. Well, what can I say? Another fabulous presentation from you, and thank you so much. Now, we have a number of questions, so please, people, don't be disappointed if we don't get through them all now. There will be time at the end to have a panel discussion. So Michelle, this might be yes or no answer for you, but the first questions are around physio techniques, such as cough assist machines and oscillatory devices being classed as an AGP or not. Now, I know you did cover that in the presentation, but
And I'm not sure if Anita's covering this in more detail, which is why I just skimmed over it. But for me, oscillatory devices are AGP techniques because you're likely to be using it in conjunction with mechanical insufflation exsufflation, and therefore dispersing aerosols that way. Mechanical insufflation exsufflation devices are definitely aerosol generating procedures.
Yep, I would definitely agree. In that document Michelle was referring to, we're more than happy that that's shared. So please reach out if you want a copy of that. Now, home mechanical insufflation. Are neuromuscular disease patients continuing with this at home? And if so, are relatives and carers having access to PPE, like enhanced PPE?
Yeah, so patients are continuing with this at home. At the start, it was a bit of a battle to get PPE for carers, but they are managing to access it based on the work from Silver, and we've also have a standard letter if it's needed. So they are having the right level of PPE for this to be used at home. We are finding that some of the families are just isolating and that they're in their own bubble and they aren't coming into contact with anyone from the outside world, and they're not using PPE. And I think that that's an entirely sensible strategy. So
I completely agree. And the use of visors is always really interesting. I loved your summary and your concept of the use of visors, you know, in addition to a surgical mask or an FFP3 mask, because there's lots of emerging evidence for that.
And what's really been interesting, Rachel, is our neuromuscular patients. You would have thought that they would have trouble with a face covering or a visor, and they don't. Mm-hmm. I mean, there is the odd one, but the majority will be quite happy to wear it, and they want to protect themselves, but they're also aware that they need to protect their carers too.
Fabulous, thank you. I know there's been some such stuff on social media recently about carer fatigue with the wearing, especially for patients who are on 24-hour ventilation and having multiple airway clearance sessions a day. But I think we are where we are, aren't we, at the moment?
And the families have taken on board a huge amount of care that was previously done by outside. And how they can keep on going is beyond me at times, but they have been doing an amazing job. But we've also found that because people haven't been mixing, and that they haven't been going out, that they've been sometimes sleeping better, that they've got their own regime, they haven't been picking, and actually are reporting that their quality of health has been better as a result of COVID. So there may be a plus side to this.
Fabulous, thank you. Now there's a lot more questions, but we'll aim to answer them at the end, and I'm sure specific ones around mouthpieces and things for peacock flow just on the chat box. So thank you so much, Michelle. As always, you're amazing. And that brings us on to our next speaker. Now, Professor Anita Simons needs very little introduction, I am sure. She is an expert in the management of acute and chronic respiratory failure, the ventilatory management, the diagnosis and treatment of sleep disorders, and of course, aerosol transmission, for which we are delighted she is delivering this next talk today. Everything you need to know. Please ask lots of questions. She's an honorary consultant in respiratory and sleep medicine at the Royal Brompton Hospital and a professor of respiratory and sleep medicine at Imperial College London, and of course is currently president of the European Respiratory Society. And she's an expert on so many panels, I just haven't got time to list them. So Anita, over to you, please.
That's really kind, Rachel. Thank you very much indeed. I'll just open up the presentation. I hope that's visible to everyone.
Yep, it's great, Anita.
Great. Okay. Well, what I'll do is I'll pick up some of the points that Milan raised earlier about aerosol generation, and I'll try and set this in context about how we do this, where we do it, and the type of patients that we're using it on. And what I will go through is just look back very briefly on the origin of this classification of aerosol generating procedures, where we've got to, again, picking up on some of the studies that Milan talked about, but some others as well. in particular reflect on the methodology, because these studies use different types of methodology which tell us different things, not always what we want to know, but and they're complementary, but I think it's an important consideration. And then, of course, come on to consequences as to healthcare workers' infection. And then I'll put it together and try and inject some controversy. So back in the first SARS epidemic in China and Taiwan, Singapore, and also in Toronto, back in 2003 and 2004, it became evident that there was a significant problem with spreading infection, not least as in Canada, about 20% of admissions to the intensive care unit with SARS-1 were healthcare workers. So this was an extremely important problem. And some of the data generated there showed particular risk factors. So on the left here, a table looking at risk to healthcare workers from endotracheal intubation and the subsequent risk of developing SARS. And you can see for all healthcare workers, there was a relative risk of just over 13. The predominant risk, the larger risk, was in nurses compared to physicians. And then again, when you looked at different types of ventilatory strategies, you can see here that there was a risk of over 2 using non-invasive ventilation. That was largely bi-level ventilation at that time. Slightly smaller risk using high flow oxygenation, oscillation. Oh, sorry, just slowly moving forward. Now, they also showed, and this is again information from Canada, that most of the infections, and we'll come back to this again, in healthcare workers and also transmission to other family members, but particularly healthcare workers, occurred early in the epidemic. So the dark blue here are hospital staff, and then patients are light blue, and then purple are household contacts. And you can see that as the epidemic progressed, at this point, there was a much better understanding of what was going on, and full PPE was introduced. And from the introduction of PPE, there was a very significant fall off in infection in healthcare workers and other family members, visitors too. And this has been a consistent factor. It happened in Wuhan, in China, happened in Italy, and I think it happened in the UK too. So the higher numbers of people, regardless of what you're doing, are infected when the situation is relatively unknown. People don't know exactly what's going on. Full PPE isn't used. There are a number of other additional risk factors. But what they did do, and it's really interesting looking at from way back then in 2003, this kind of hierarchy of risks that they generated, showing high risk, which they attributed to aerosol generating procedures and a short distance from the index case, and then going through a number of other exposures, cough-inducing procedures, and then finally to relatively minimal risk of being infected with long distance from the patient. So already at that point, they'd kind of generated the hierarchy of risks, which we've continued to use to today. It's a little bit slow in moving forward. Now, what they also did, as well as looking at infection in healthcare workers, they looked at super spreading events. And I think this is also particularly relevant to SARS-2. And they looked at super spreading events involving 3 cases, 4 cases, and 5 cases. And as well as looking at the type of procedure done, they considered these other environmental staff factors and also host factors. And so if, for example, there was very short distance, minimum distance between the beds, this is odds ratio. There's a very significantly elevated odds ratio. If staff were working who were having symptoms, then they were likely to spread the infection. Again, high odds ratio. And again, with patients who were highly symptomatic, there was a very high odds ratio, with a rather variable odds ratio with using bi-level ventilation, and a higher level, in fact, with requiring oxygen therapy. Now, subsequent to that, a few years ago, there was a meta-analysis done trying to pull together some of the information that was gained both in SARS-1 and also subsequently in MERS and H1N1 flu outbreak. And for odds ratios here, you can see the pooled estimates for tracheal intubation, 6.6, a risk of generating infection. A suction, you can see raised, but actually suction before intubation compared to after intubation, somewhat odd. Another raised rate for manipulation of oxygen therapy, which is oxygen masks, lower in bronchoscopy, and then you see this risk again coming through 3.1 for non-invasive ventilation. And really based on all that data, this is where we are to this day. These are Public Health England's, the list of aerosol generating procedures, and it's pretty much the same as WHO, CDC, all others. So intubation, extubation, tracheostomy, bronchoscopy, interventions requiring suction, drilling interventions, but also non-invasive ventilation, as we know, CPAP, high frequency oscillation, and also high flow nasal oxygenation, high flow nasal oxygen. And in March, April, the infection control guidance, which was issued then, was, as Milan said, it stressed at that point that the predominant mode of transmission was assumed to be by droplet and contact, and that aerosol generating procedures were considered to have a greater likelihood, so this is a definition, a greater likelihood of producing aerosol compared to coughing. And this was to contrast it with what was thought then to be the airborne route of infection, where the R value, so the transmission rate, is much higher, such as in pulmonary TB and in particular measles and chickenpox. Now, this has really focused on this classification between what is an aerosol and what is a droplet. And in essence, as you know, an aerosol using this kind of classification is defined as a particle less than 5 microns in diameter, whereas a droplet is more than 5 microns in diameter. And that has important consequences because diameter determines the mass, and the larger mass, say of the droplets, mean that they are likely or assumed to be likely to travel for shorter distance and drop out around the patient at a shorter distance from the individual, compared to aerosols, smaller particles, which are likely to be airborne for much longer for a variable amount of time. And as a result of that, there have been, as we heard, and also in the questions, a relative disinclination or advice to use aerosol generating procedures with caution. And the CDC recommended minimize use of aerosol generating procedures. And I think this contributed to this, or possibly could be a factor contributing to this really high level of intubation in this early series coming from New York. And in fact, all the patients, nearly all the patients were intubated, and a very high mortality rate. Now, there are a number of criticisms of this paper in that the analysis of the data was not brilliant, and many of the patients were much sicker at that time. And we know that mortality rates have fallen in the second wave compared to the first wave, but there was certainly a high tendency to intubate patients early and not have a trial of non-invasive support, CPAP, or high flow nasal cannula therapy first. Again, an editorial or thought piece in Lancet Respiratory Medicine generating this concern and about the use of non-invasive ventilation, and other papers too. And with some reason, but also a high level of caution. But as we heard earlier, and as became clearer as the pandemic progressed into the summer, there was a rethink going on, and that was based on many nice studies, some based on largely physics studies, but really on the new thought, really, that just to have a biphasic classification, that you have aerosols and you have droplets, and you can make decisions based on those, is really basing your thinking on a very arbitrary classification. It's also, we can see that this is a sneeze. We heard that cough is similar, possibly won't travel as far, but is a really major factor, as it's a cardinal feature of SARS-2 as opposed to SARS-1. You can see gobbets dropping out quickly, aerosols here, but it's evident too that in a biological aerosol, the characteristics of that this group of particles changes, and it will change related to humidity, evaporation, and that some droplets, depending on the relative humidity and the temperature, evaporate to become small droplet nuclei, and they can behave in the same way as an aerosol. Also, we talk a lot about particle size, but what really matters is whether those droplets and particles are carrying virus. And even if we sample viral antigen within the material, in the droplets, aerosol, whatever, we don't know whether that viral material is actually infectious. And therefore, a number of other factors, such as we talked about earlier, environmental ventilation, the kind of room, the size of a room, and also the duration of exposure of the individual with the patient become extremely important considerations over and above the type of aerosol generating procedure. And by July, it had become clear with the papers that we discussed earlier, demonstrating that infection was occurring in situations where it couldn't be droplet or contact spread because of dispersion, and the aerosol transmission plays at least a part in the transmission of SARS-CoV-2, and it's not just droplets and contact fomites. Now, just as I go through the data, I'm just going to touch on a number of different papers illustrating different ways evidence has been generated. I think that's important because some of the experiments that we compare and contrast demonstrating whether these procedures generate particular size particles vary in what they can show us. So we have a number of studies where it's predominantly visualization of the particles that's demonstrated. And here you can see the relative volume, the direction, distribution of the plume. And there are different ways that you can visualize those droplets. You can use smoke particles. You can inject fluorescein, nebulize that into a high fidelity simulator, and then backlight it and demonstrate the fluorescence spread. You can also measure the particle size and quantity. So I'll show you some experiments where that's done, and usually that's done with an optical particle sizer. And there you know whether you've got droplet or aerosol because you know the exact size, which you don't have an idea of. You get no exact measurements from the visualization techniques, and you can sample at different times and different distances from the patient. There are then studies which I think are important, complementary studies, where the virus is quantitated. So you can look at viral RNA, and you can culture it and see whether it's actually infectious. Because in essence, if that's not happening, if that's not there, then it doesn't really matter. You're not going to infect anyone if there's not virus there, or there is not virus which is infective. And then finally, really key outcome measure is the number of healthcare workers who are doing these procedures who are infected. Really important to have control groups because there is work, as you know, done showing that many healthcare workers may be as likely to be infected as at home within family groups as within hospital during their day-to-day workload. And also, if possible, to have evidence, well, we hope they don't happen, but if they do, a careful analysis of super spreading events on the ward. But having said that, there are these modifying factors that we have to take into account, which I think really does affect the interpretation of studies. So quite a lot of the studies are done using smoke particles and high fidelity human simulator models. Smoke particles are very small. Human models don't behave, of course, in the same way as human studies themselves, because you don't get a biological aerosol, you don't get these different size particles, and you don't get the effects of the humidity and temperature changes and so forth. Next, we have the host factors, and I think it's also becoming clearer in SARS-CoV-2 that, you know, we're not all equal, that a lot of spreading is done by super spreaders, that there are people who are spreading to far more cases than other individuals. And although we have an R0 factor, which we use as a very important index of whether we go to different levels of protection and so forth, that there are some patients who are going to disseminate far more infection than others. And then lastly, as we talked about, there is the environment where this procedure is done, and the amount of time the individual who's caring or applying the aerosol generating procedure to the patient spends with them in that environment, the number of air changes, the ventilation and so forth. Right, so just quickly touching on these different sorts of methodology, these are the sorts of visualizations, smoke and light, so they're backlit. There's another sort of imaging procedure here that is done in some studies. You can get beautiful pictures from this, enhancing your chance of getting your paper published, I think. But it's very difficult, especially here, and to some extent difficult here actually, to quantitate the size of the particles and also the exact quantity of them. There's another light scattering way of looking at the plume and how it spreads, what direction it goes in, which can be very helpful too. And then there is the particle sizes. So just to look at those, I'm just sampling studies here, so showing you a number of studies. If you've done studies in this area, I do apologize if I haven't shown your study, because there's some brilliant studies, but I'm trying to show the type of studies. So here, this is looking at chest compression during resuscitation. This is a human simulator, and they nebulize sort of fluorescent labeled particles, and then with the lighting demonstrated the flow from the compression. And we've all seen this cover of thorax, looking at the spread or not through different types of face coverings. And then David Huey has done some lovely experiments, again with simulators and again with smoke and backlit lighting, where you can compare and contrast non-invasive ventilation with different types of interface, and also high flow nasal cannula oxygen therapy here. And as we've heard, if you can seal off, cover the interface, then you reduce the spread. So these are interesting experiments, but they tell you certain things. This is a sort of compound, a gathering of data too, looking at high flow nasal cannula therapy versus standard oxygen therapy through non-rebreathing mask or Venturi mask. And this was relatively reassuring, showed that high flow compared to these other oxygen delivery systems, and looking at dispersion, so smoke dispersion, this is, there was not a very significant difference between these, and even at high flow at 60 litres a minute compared to the Venturi mask, so similar levels compared to standard oxygen therapy. This was a study that Milan mentioned, and this was done in humans, and this was done at the time of H1N1 with individuals with coryzal symptoms, so runny nose, cough to some extent, and comparing NIV in these human subjects compared to the modified NIV circuit. And this was with the non-vented mask with an exhalation. The exhalate was filtered. It's the first time we put the filter in that circuit, compared to oxygen therapy, and this was pre-high flow nasal cannula therapy, so this was oxygen at 16 litres per minute, and then the nebulizer. Bottom line here, that's the optical sizing system, was that the NIV, as Milan mentioned, generated large droplets, so over 10 microns, but when the circuit was modified, then that level of large droplets was not generated. Oxygen didn't generate droplets. The only aerosol generation occurred from the nebulizers you can see here, but the exact characteristics of the aerosol were those specified by the nebulizer themselves. So this was a nebulizer set to generate these small droplet sizes, and it's inconceivable that a patient could mimic generating the droplet or the aerosol spectrum of that size. So nebulizers generate aerosol, but they generate aerosol of the drug from the nebulizer. And this is a more recent study too, just re-exploring this important issue of intubation and extubation, because so many people seem to be develop SARS-1 after that. Again, they used human subjects and they used the optical particle sizes, so they could look at the actual size of the particles, and they actually showed that intubation and extubation were not increasing the small aerosol particles, and the bigger generator of particles was actually cough. So this is where comparisons can become a little bit difficult, because if you did a whole series of intubations and experiment and the patient didn't cough, although of course it's quite common that they do, then you would get totally different results than if the patient did cough a lot. And so some of the variables that we need to take into account aren't the ones that you would normally expect to, but I think this is a very helpful study. Moving on to the next level of evidence, which is actually sampling virus, and this is by PCR and then culturing it. So this is predominantly this study, and again a very recent one. In different environments in patients' rooms, can you actually sample virus? They showed again too in the study that different particle sizes were produced by cough relative to breathing. So for the smaller particle sizes, not surprisingly, it was breathing, just normal breathing, more than cough. But for the larger particle sizes, it was cough more than sort of tidal breathing. And the bottom line from this study, in the interest of time, was although only one of these patients was receiving high flow nasal cannula therapy here, they didn't, when they sampled, this is undetected, they didn't sample viral material in the room of these patients, although only one was receiving high flow, as I say. And as I understand it, well, I very much hope that during the recovery RS study, there will be a sub-study where there is environmental sampling with personal samplers, so you can wear these little button samplers of viral material that then can be cultured within the room of patients who are randomized to oxygen, CPAP, and high flow nasal cannula therapy. So that should be helpful information. Now, I won't dwell on this study because it's a very complicated paper, this, which is in preprint form, but I have every reason to believe it will be published because it's from Marion Koopman's laboratory in Rotterdam, which is a very good one. They did a lot of work, a lot of synthesizing work, again, looking at the distribution of aerosol droplet, and showed a big mix in coughing compared to breathing, singing. But they also looked at a viral load and transmissibility. And to cut a long story short, they did see relatively similar viral loads. So this is in PCR sampling from the patient, relatively similar viral loads in symptomatic patients compared to asymptomatic patients, but the transmission and the spread of the droplets was much higher where patients were coughing. So symptomatic patients who are coughing are a key problem. And the study is also a very interesting one because they looked at SARS-CoV-2 and compared with other viruses such as H1N1, and the biggest heterogeneity in transmission was actually seen in SARS-CoV-2. So this is a particular virus. Now, we saw this data from the Italian group who looked at provision of CPAP NIV and high flow in the high dependency unit, and about 11% of their staff developed infection, developed COVID, again, predominantly in nurses as opposed to other groups, although there may be a slight different classification of physiotherapists, but it's, you know, there is a strong signal coming out here of duration of exposure, as well as so spending a shift with a patient as opposed to going in, assessing them, or even doing a physiotherapy session. I'm just coming towards the end, as I appreciate there's a bit of time pressure, but this has just been published in the last few weeks. I think an important study reviewing healthcare workers and controls and family members in a large study in Scotland. You can see that they compared healthcare workers who were patient and non-patient facing. They then looked at the household members of these healthcare workers, and then they had matched controls. Sorry, let's go back. And if we look at the graphs, you can see here, the comparator population is the purple line at the bottom. And then you can see relatively similar to that, you have non-patient facing healthcare workers, so not a big increase. Here's the patient facing healthcare workers, so significant increase. They broke it down from men for men versus women healthcare workers. Significantly bigger increase in healthcare workers who were men. And there's also further data in the paper about healthcare workers and comorbidities. And there was, compared to the control group, a small increase in the risk of infection in the family members, so household contacts of the healthcare workers. Now, important to say too that this was in all of these individuals, the infection was demonstrated in people who'd been admitted to hospital. So these were hospitalized infections in healthcare workers and their contacts. And the reason to do that was that you can be sure, you can ascertain that they've got COVID, whereas there's always some doubt for community cases. Now, what they did then, very helpfully, is that they took the patient-facing healthcare workers and then separated them into, well, we have the control population, and then they separated them into healthcare workers that were standard procedures, but not aerosol generating procedures. They separated them to those who were working in intensive care. And then this pink line is the patient-facing healthcare workers who were delivering aerosol generating procedures. And these were largely respiratory people, much like I suspect many people who are listening to this session today. Now, some key points to set it into context is that for the intensive care group, there were 5 people. So this represents a total of 5 individuals. Bear in mind, we had 150,000 total group at the beginning. And all these 5 individuals were infected right at the beginning of the epidemic. We then have the frontline healthcare workers. So important point here, this yellow group are those who are working in accident emergency departments, they're paramedics, ambulance staff. So these are the front door people. And then the aerosol generating procedure ones and those who were doing other patient facing work but not aerosol generating procedures. The only group that had, well, the important group that had a significant risk, you can see here, are the front door workers. And as I mentioned, the intensive care group did have a high relative risk, as you can see at the bottom. And the relative risk was 1.2. For the non-ICU aerosol generating group, so this is about 7 people here, but the confidence interval was so wide, although you have a value of 1.9 as your hazard ratio, that did not achieve significance. And the only group that achieved significance compared to the comparators were the group of frontline workers. So although there is some risk, I'm not trying to minimize it, some healthcare workers did get infected. Actually, the bigger group were those working in A&E, paramedics, and so on. And then just last study before I finish, this is relatively reassuring work, I think, from China. and this was looking at antibody levels, so people who had evidence of infection, IgM and IgA antibodies, and comparing the levels of those antibodies in patients who'd recovered from COVID, which are the pink group. And then they looked at frontline healthcare professionals who were delivering AGPs in yellow and compared them with control healthcare professionals who weren't delivering AGP. And the important point about this work is that adequate PPE was provided and it was used effectively. So from this study, you could conclude that if PPE is adequate and it's used, there was not a significant increase in risk to frontline healthcare workers who were delivering aerosol generating procedures. So I want to summarize now that we know now, and this is something different that we didn't know before, that aerosols are a factor overall in SARS-CoV transmission. We can also say that not all aerosol generating procedures generate aerosol. Many, in fact, generate droplets, although some may generate aerosols. I think an important, I don't think it's semantics, but I think an important point is it's the patient who is the aerosol generator and indeed the droplet generator. And these techniques that we deliver may enhance dissemination and transmission risk, especially in patients with high viral load or who are super spreaders, and when used for long periods in areas without suitable ventilation, or air changes in the room, and that of course within our host patients the infectivity may vary, which will very much affect the level of transmission. It does seem that adequate PPE is effective, and then I would argue that there is an overwhelming focus on aerosol generating procedures. Understandably, those of us who do it are interested in it, but our infection control people, the infectious diseases specialists, are highly focused on aerosol generating procedures. And as a consequence, there has been some discouragement of NIV use, NIV and CPAP use. But I think a secondary really important consequence is this deflects attention from key risk areas, such as coughing patients in accident and emergency and for frontline workers, and of course in social care in care homes. There is a clause, a get out clause in the Public Health England guidance, in that it does suggest that local risk assessment should be made. And I do, strongly suggest that where we've gone wrong and where the majority of healthcare workers have been infected, it's been at the beginning of the epidemic where there's been inadequate PPE in people who we don't suspect are going to get infected, but a coughing super spreader is likely to be probably more risk than someone quietly using CPAP or their standard NIV in a room with adequate ventilation in the healthcare worker using full PPE. And this is just food for thought, really, but I suspect this may be an example of anchoring bias, which is something I've only heard of recently, but is a concept. This occurs when you enter an area of unknown, such as it was when we first started to experience SARS-CoV-2. We didn't know what was going on. There were many, many unknowns, but we did hold on to some things we did think we knew, and that was about aerosol generating procedures being highly risky, and we had to be careful about them. I'm not by any means saying that we shouldn't use full PPE and we should use them with common sense, but I think it means we've missed some other important considerations. And with that, I'll finish. Thank you.
Thank you very much, Anita. That was a very intense presentation. I think it'll take some digestion for me, that one. But thank you very much. A very comprehensive review of anything to do with aerosols. I think it's reassuring that PPE works. And I think that we've certainly found that in our institution, that where we've been wearing PPE, spread among staff members is virtually none. And I think that that's a great take-home message and reassures us, so all of us who are involved in these aerosol generating procedures, that actually we can rely on our PPE fitted correctly and used correctly. I'm sure there will be many questions through the question portal. There's not much coming up on chat at the moment in terms of questions. So I'd like to thank you, Anita, and move swiftly on to Stephanie Mansell, if I could. Stephanie is a consultant physiotherapist at the Royal Free in London, and has got a vast experience in dealing with remote monitoring. So I'll hand it over to her. Thank you very much.
Thanks, Martin, for the introduction. So we've been using modems on the back of all of our ventilators at the Royal Free since 2014. So I'm hoping to be able to share some of our experiences with you all this evening, so that you can hopefully not have to make some of the mistakes that we made, and so that if you're thinking about implementing modems to help you during the pandemic, that our experience can help you with that. So my talk's going to touch briefly on some of the literature for remote monitoring. I'm going to think about the opinions of patients and carers, but also healthcare professionals on using the modems. I'll touch upon some of the pros and cons, and then lastly, I've got a few case studies towards the end, because I think that really helps to see how it works in clinical practice. So the first thing I'd like us all to consider is what we mean by remote monitoring, because different terminology and different equipment means different things to different people. The ERS had a task force that tried to define some of this terminology, and then came up with 15 different terms related to telemonitoring, which is ideal because it helps us to all ensure that we're talking about the same things. And so just to be clear with everybody today, what I'm talking about when I mean remote monitoring is the modems that plug into the ventilators and connect to web-based platforms. And in the UK, we've got 3 different platforms available to us. So we have AirView from ResMed, Encore Anywhere from Philips Respironics, and then Everywhere from Brias, which I understand will include the NIPI 4s as well. So if we think about some of the evidence base for using modems and ventilator data in our home mechanical ventilation cohorts, Annabelle Pinto did this study in the ALS or MND patients as far back as 2010. And it was a randomized control trial with 40 patients. The control arm were living in central Lisbon, and had routine care without the modems. The intervention group all lived outside of the city centre and all had modems on the back of their ventilators. They did have some exclusion criteria, and so patients with gastrostomy tubes, for example, were excluded, as were patients with cognitive impairment. So it's not completely translatable to all of our patient cohorts, but certainly includes most of our MND patients. What Annabelle and colleagues found was a significant reduction in both emergency room visits and hospital admissions as well. The office visits, you can see, were much higher in the control group, but that was because that was the patient pathway demanded it and made it necessary for them to have more office visits. So although that also was statistically significant, I don't think you can say that was the intervention that had quite that impact. What they definitely saw was a reduction in hospital admissions, so very reassuring. They also produced some survival data. Now, the study wasn't powered for survival, so we do have to take this with a pinch of salt, but you can see here that there was an improvement in survival in the patients who had modems. And the authors speculated that this was from a combination of the system alerting them to problems, which allowed for early intervention for when patients were having difficulty, but also that they saw much better compliance in the patients who had modems, because they were able to optimize ventilator prescriptions remotely and also able to intervene when patients were struggling with their NIV. So that improvement in survival is probably due to the associated increase in compliance. They did also produce some cost effectiveness data. That QR code on the screen will take you to the paper because it's tucked away in the neurology world rather than the respiratory world. And they looked at both hospital costs and annualised NHS costs. And when they took into account the annualised NHS costs, they saw a significant reduction in cost in the modem group. And they used tariffs to calculate that, and they think that they saved around €700 per patient per year. And bear in mind that was 10 years ago now that this study was completed, so we may well see even greater cost savings now. Borrell in 2015 looked at whether we can use some of the ventilator data to try and predict exacerbations in our COPD patients. They used the Exact Pro questionnaire to try and identify the point of exacerbation. And what they demonstrated was that where patients had an abnormal day, that was potentially an indication of exacerbation. And specifically, it was the respiratory rate, the percentage of trigger breaths, and the NIV usage that potentially indicated an exacerbation. Just bear in mind that was both an increase above the 75th centile and a reduction below the 25th centile. So this work potentially tells us that the ventilator data could help us to detect exacerbations, but certainly needs a lot more work to establish what that looks like for individual patients. And then more recently, Ando and colleagues looked at a combination of using ventilator data, which was actually collected through SD cards, because they used the Trilogy in this study, which doesn't have the capabilities for modems on the older version. And this was a 6-month trial. They also looked at oximetry data and patient symptoms. Patients completed a symptom questionnaire twice a day. And on average, they received 5.7 notifications per week for 1361 different interventions in response to the alert system. Some of that included accessory provision, so patients needing new tubing or new masks. Some of that was ventilator prescription amendment. They had 3 elective admissions and 1 outpatient appointment. And what they reported was that 23% of the participants over the 6 months avoided the need for an outpatient appointment using this alert system, which combined those things I've mentioned. So when we launched our use of modems here at the Free, we wanted to see what the impact of using that NIV data would be. So none of the patients had ever had their data downloaded, and modems weren't in situ. So we downloaded all of their data, and then we made adjustments to the ventilators to optimize ventilation, try to minimize leak on the interfaces, and also to try and improve compliance. And we found that we were able to ventilate patients much more appropriately. So they were closer to ventilating at 10 mils per kilo of ideal body weight, which is the measure that we use here. And we also saw a significant improvement in compliance in terms of percentage usage. So similarly to Annabelle Pinto's work in terms of being able to improve compliance. We subsequently went on to conduct a qualitative study with that same group of patients that looked at their experience and views, because I think there's a real lack of evidence on the qualitative side in this world. We really need to understand if it's acceptable to our patients. There's no point implementing technology that they're not going to use. And we had a number of themes that arose from that study. So our healthcare professionals reported an improvement in efficiency. They felt they were able to deal with patient queries in a much more efficient way, and that they could prep for outpatient clinics, which meant that the interactions they were having with the patients were much more efficient and effective. And they also reported a reduction in necessary appointments. So across the narrative, all of the focus groups, clinicians felt that the system was definitely effective, but they didn't necessarily feel it had saved time. So it makes better use of time rather than being time saving. There was concern from our healthcare professionals that some of the patients were becoming complacent. So this concept that because they're being monitored, that if they have a change in their symptoms, that they won't necessarily seek healthcare intervention because they think that they're being monitored and someone will contact them if there's anything to worry about. And certainly for some of the patients, they reinforce that message. So there was an assumption that because they've got monitoring on, that if there's a problem, someone's going to contact them. And for us at the Free, this has been instrumental in our conversation with our patients, and something that's really changed clinical practice from conducting this research. So we now have very clear conversations with our patients when they're initiated on treatment regarding the modem and what that really means. And that certainly really helped us to make sure that they're aware that we don't have the capacity to be checking on them every day, and that if they're having a change in any of their symptoms, that they should still seek healthcare intervention. Many healthcare professionals have expressed a concern regarding surveillance, so that big brother effect, that we might be unduly scrutinising patients' lives, and that might impact on the patient-healthcare professional relationship. But that was very much an opinion that was expressed by the healthcare professionals, and that wasn't echoed by the patients at all. So there were no concerns in the patients that we interviewed regarding that concern of big brother effect. They weren't concerned about invasion of privacy at all. Some of our healthcare professionals were concerned regarding the ethics of having modems, having data, and not necessarily being able to check that regularly, and where that might land them if there was a complaint or an incident. Our patients, on the other hand, reported that they felt much more confident in the ability of the healthcare professionals to look after them and to manage their care. So fairly conflicting themes that arose there. So then if we think about the unanswered questions that we have for remote monitoring, we're not completely sure what the best data to collect and review is. And that's quite clear from Borrell's study, is that we need to do a lot more work to establish what data is best to collect for what patients when. We're unsure whether there's an increase or a reduction in healthcare utilisation. Some of the other telemonitoring studies demonstrated an increase in healthcare utilisation, and the UK-based study, the Telecroft study, which was conducted by Michelle and Anita, showed an increase in healthcare utilisation, but that was much more of a traditional telemonitoring rather than using ventilator modems. We might need more resource in order to be able to deliver this, although our qualitative study certainly showed that overall healthcare professionals felt it was more efficient. I think we do have to consider the ability of our clinicians to review the data that's provided by the software. I think there's a big training need in the sleep and ventilation field of our understanding of that data and what it's really telling us and what it's really showing us. And that obviously varies from manufacturer to manufacturer. So it's really important that we've trained our clinicians in order to be able to interpret it. It could potentially help us to identify exacerbations, could help us to reduce planned outpatient visits. And I guess we have to think about whether it's better for a subset of home NIV patients. We have them routinely as standard care for everybody, but I know other services are using it for different subsets. So is it more appropriate for those neuromuscular patients? Is it better to use it at the start of treatment during that initial initiation phase? Or is it better for end of life patients who might be nearing the end of their journey? And I think we do have to consider the impact on self-efficacy. Our qualitative study showed some concerns around complacency, and the Telecroft study has also demonstrated that monitoring might reduce patients' ability to self-manage and might reduce their self-efficacy. So that's something we need to consider when we're implementing this type of technology. There's certainly lots of pros. As I said, we've been using it as standard care since 2014, and we haven't stopped doing it, so we're certainly finding it beneficial. We have quite a big geographical spread of patients. We're quite a small team, so for us that allows us to look after patients without having to bring them to the hospital. The Royal Free is notoriously difficult to get to and has almost zero parking. It definitely facilitates telephone problem solving, can help you to prioritise your real problem patients. So when you're strapped for resource, as we all are, even more at the moment with having competing pressures on our time, it helps you to make sure that it's the problem patients and the ones that are going to benefit most from your intervention and that you're using that precious time with. I think it's a fairly consistent message across the literature that it does help to improve compliance, and it also helps to ensure optimal ventilation. we find it definitely helps us with our outpatient initiation and our outreach service. So we do very few inpatient setups. We don't have designated inpatient beds or a designated unit, as will be the case with many HMV services across the UK. So having the modems allows us to be able to provide both that outreach service and that outpatient initiation, knowing that we'll be able to tweak some of the nuances of the settings in order to make sure the patients are safe and having effective care. It reduces the need for routine appointments, and it definitely reduces the need for face-to-face appointments in a pandemic. Many of our patients are shielding, and I'm sure you're all experiencing similar frustrations when you really do need to see them in outpatient appointments, that they simply don't want to come through fear of contracting the virus. So in terms of some practical tips then, if you're thinking about you starting to use modems or you're just stepping into that area, I would definitely take the time to set your patients' expectations and consider the narrative that you'll be having with the patients. You need to make sure that they know that you can't see or hear what's going on in their bedrooms. You need to be clear with them about how often that data is going to be reviewed or monitored, so that they're very clear about when to still seek healthcare intervention. I would urge you to make sure that the modems are connected and dialing correctly at the point of setup. They are technology, and we all know how technology can fail us at times. So really taking the time to ensure it's working at the setup will definitely reduce the burden for the patient, their carers, and for you when they're then in their own environment. There are both cellular and Wi-Fi modems available, and there's pros and cons to both of those. So the Wi-Fi modems allow you to send more data. So you can consider things like adding oximetry. You can get breath by breath data using the Wi-Fi modems because they've just got more capacity to transmit more data. But they are more fiddly to set up, and it does require more intervention from the patient. So the patient has to connect it to their Wi-Fi, and the patient has to have Wi-Fi in the first place for that to be an option. The cellular modems require much less intervention from the patients. You plug them in, you set them up, and then they shouldn't really have to do that much with them. The downfall of them is that because they're cellular, that they transmit less data, and so you can't get the breath by breath data. And when we've tried to do oximetry through the cellular modems, we've struggled to get that data across. So pros and cons to both of those, but my overall advice would be to go for the cellular data modems. We have had no issues with information governance at the Free. They signed off on our information governance for the systems without any bother, but I know many services have had lots of issues with getting sign off from information governance. Given the situation that we're in, I don't think they should be causing delays, and if one NHS trust signs off on it, I struggle to understand why another trust won't. So if you are having difficulty with information governance being a blocker, I would urge you to contact the NHS digital arm of what is now NHSX, because they can then help to facilitate conversations with your IG team to try and help resolve whatever the problem is. A word on flags then. So all of the systems have an inbuilt flagging system that will flag up to you if the patient's having particular issues. So that might be compliance, it might be low tidal volumes, it might be mask leak, it might be residual AHI. There's a whole host of them that are built into the system. What I would really urge you to do is to consider which flags are most appropriate for your cohort of patients. So you will all know your patients and your cohort best, and you'll all know which flags are going to be most useful and most relevant to your service. So I'm not going to dictate to you which ones to use, but I would say don't just use the standard ones that come with the package, and this is why. So within 1 week, before we took the time to stop and think about the flags that we were using, we had over 3,000 flags. And as I've said, we're quite a small team, and that's just simply not manageable for us to be able to address all of those flags. And many of them aren't particularly relevant. So if a patient's having a low percentage of trigger breaths, well, that might be helpful to know, but is that going to really change your clinical practice or what you're going to do with that patient? I would say it probably doesn't. So we've reduced our flags. We're only using now the compliance flag, the leak flag and the tidal volume flags, and that's reduced the numbers of flags that we're getting to much more manageable numbers. So please do think about which ones you're using and take the time to really think about that. I just wanted to touch upon monitoring and the different ways in which we could potentially monitor our patients in the community. Blood gases are obviously the gold standard that many of us have been using for many years, but they're certainly logistically challenging to obtain in the community for many areas. And they only give us a spot check in time, so they might not detect ongoing nocturnal hypercapnia or hypoxia. And tidal CO2 sounds like a dream. Just give a patient something to breathe into and that you could measure CO2 in the community. But as you'll all know, it's not routinely available outside of critical care areas, and it's not particularly accurate for those who aren't on invasive ventilation. Transcutaneous CO2, many of you will have used that in clinical practice, and you'll know it can be difficult to set up. It's certainly a more expensive method of measuring CO2, and it's currently not remote, so it currently doesn't interact or is able to send you that data remotely. So it requires you to package it up, to courier it to the patient, for either the patient or the carer to be dexterous enough and intelligent enough to be able to set it up, and then it requires a courier to bring it back again for you then to have to download it and compare it to the other data sets that you're getting. We've certainly had quite high failure rates in trying to get patients to do this themselves. And so it's certainly an option, but I think it definitely has its limitations. Bicarbonate levels might be more routinely available in the community and might be something that is easier to get GPs to do or district nurses to do. Ari Manuel's work has shown that that can predict ongoing hypercapnia, and so that's a much cheaper and potentially easier method to use. Overnight oximetry is certainly cheap, it's certainly easy to use. There's many methods that will connect into the ventilator to give you simultaneous ventilator data. And there's been some more recent data suggesting it might predict survival in the MND patients. But we do have to bear in mind that an adequate overnight SpO2 doesn't necessarily exclude hypercapnia, and the thresholds that we should be using remain unclear. So various authors have suggested various thresholds ranging from 10% with time below 2%, and we don't yet really know what the threshold should be for patients once they're established on treatment. The positive airway pressure therapy parameters then are what we get from the modems. The AHI has been found to be pretty accurate, and there's various authors that have looked at this, comparing the ventilator data with limited cardiorespiratory sleep studies. And so we know the AHI is accurate and something that can be considered reliable. The tidal volumes are probably underestimated on most ventilators. The bench studies were all done quite some time ago, so they haven't been conducted on the more recent models. I think the Trilogy there is some data on, but most of the bench studies were done on older ventilators, such as the VPAPs and the Harmonies and Synchronies. It is also very dependent on leak. So as soon as there's high mask leak, pretty much all of your other parameters become unreliable. So if you're seeing very high mask leaks, then I wouldn't even bother to look at the tidal volume because it's simply not going to be accurate. So moving on to a few case studies then, so I hope that will help to highlight to you how we use this in clinical practice. So this was a patient who was a new one to therapy. She was a previous CPAP user. She had pretty high levels of anxiety and was reporting a lot of claustrophobia. And so she was issued with one of the minimal contact full face masks, which sit under the nose and come around the mouth in clinic in an attempt to reduce her anxiety and claustrophobia. And through remote monitoring, we could see that there was ongoing high leak with this particular interface. So a simple telephone intervention meant that we could send out a full face mask to that patient. The fact that we'd already trialed the minimal contact mask meant that she was able to come to terms with the need for the full face mask much more readily. And you can see here this significant drop in her leak here, a much better mask fit. This is what the night-to-night data looks like, just to give you a bit more detail. So you can see here this large leak for large portions of the night with the minimal contact mask. And then with the full face mask, nice stable mask fit. And so we were able to resolve that issue without having to bring the patient to clinic because we'd already fitted her for a full face mask and she already knew to expect that. This patient was a patient who's got end-stage neuromuscular disease. He's been known to the service for many years, and he'd had multiple attempts with multiple clinicians using multiple approaches to try and establish him on NIV, and he just simply was non-compliant. He's got quite a complex social situation and complex psychology. But he presented with extreme hypercapnia and acidosis and was admitted and had acute NIV to try and correct that. During that inpatient admission, we were able to re-establish domiciliary NIV, and we were able to discharge him home with that. So you can see the date of discharge here. So this is all of his hospital usage, good compliance. The minute he goes home, he stops using it. But with regular phone call support to establish NIV at home and regular support for the wife who's struggling with significant levels of carer burden, we have been able to re-establish a good pattern of usage for him at home. And without that ventilator data, we wouldn't have known that he'd stopped using it, and we wouldn't have been able to make an early intervention to try and resolve the issues. Although it is really support and carer support that's the thing that's able to improve his compliance. And then finally, a patient with obesity related respiratory failure who was admitted in type 2 with acidosis, had acute NIV to resolve his acidosis. This particular patient is schizophrenic and lives in a supported living environment. We were able to get funding for him to have a trial of home NIV in his own environment with waking night carers to try and facilitate that. He doesn't have capacity, and we wanted to be able to give him the best shot possible. However, despite our best efforts and lots of input from us, and despite the best interest of his carers, who I have to say were absolutely fantastic, we weren't able to establish him on NIV in his own environment. And as you can see here, his usage just simply wasn't going to be adequate to make any difference to his outcome at all. And so we were able to have a best interest discussion with his carers about withdrawing the NIV. And I use this example to highlight to you all how using you can monitor it from the hospital. And so it was really powerful to be able to use this as an example of also withdrawing care as well as helping us to optimize care. So I'd like to thank you all for your attention, and I'm hoping I've got time for a few questions.
Steph, thanks very much for that really comprehensive review about remote monitoring. And as I said, it's great to see that the years of experience you guys have had is, being able to be shared more widely now. It's something that we haven't done traditionally, remote monitoring, and our hand has really been forced by the pandemic to bring that in. And I think it's really interesting to see how those data can be used. There was one comment, and you mentioned it briefly, but just to play to that, in terms of transcutaneous monitoring, there was a reference to the fact that there are some newer devices that do have that built into it. Do you have any experience of those, or do you think that the cost of those will be prohibitive for using them in general?
I think the cost is prohibitive, and also to get good quality TCCO2 data, you need someone that's able to put the sensors on, and the reality is in the community we're just really struggling to get patients and carers that can do that and for us to give us quality data.
Yeah, I think we have been looking at this. Interestingly, in paediatrics, they're using it pretty effectively. And I think that's because paediatrics, often they have parents who are already highly skilled carers. So I think for some patient groups, it may be an option, but clearly for lots of patients, that level of support is just going to be too much, I think. We're
doing a lot more oximetry, which is definitely helpful in, when we can't get capillary blood gases, that will at least give us something to know how adequate and effective the ventilation is.
No, agreed. And using that combined with the remote data that night, looking at leak and so on, I've found very useful actually with that combined. But thank you very much. And we are running a little bit over, so I apologise to everyone, but we still have the UK group in June this year. There will be, for those of you webinar, if you be able to fill in your feedback forms at the end, you'll be able to obtain a discount on registration for the summer meeting, which hopefully we'll be able to see more people in person rather than remotely. I just wanted to bring in very quickly, as we've still got so many people online, just one question, that are outstanding that have come in through Twitter, and Rachel will direct those to the couple of panel members that are still here. Thanks very much.
Thanks, Paddy. This is going to combine quite a few questions actually. So I don't know if Michelle and are still there and relevant. I suppose confusion around that in terms of definition is that aerosol generating procedures produce aerosols that can have a transmission risk, and cough is a droplet procedure or effect, if you like. And when we're thinking about procedures or interventions that we do that potentially are AGP, like aerosol generating, it's important to think about, are they a single intervention? So something that will just make someone cough that could potentially be a high risk droplet transmission versus something that is sustained and repetitive. So if we think about the use of mechanical devices, which is sustained and repetitive as part of chest physio, if we think of like the spirometry in a lab versus a cough using an LVR bag, for example, there's still quite a lot of questions coming through, and I think it's because of lack of consensus maybe, and because it's not covered in PHE guidance. And the second part to that is around certain cohorts of patients who have probably high risk of transmission. For example, your chronic chest patient who coughs a lot but doesn't have COVID. That's a lot I've just said there. I don't know if all that makes sense, but the real question is probably just a little bit more explanation about the definition.
Yeah, I see where everyone is coming from, and I think one of the real problems we might as well be honest about is that these very the definitions we use don't really pan out in practice, because much more risk in an accident and emergency department with a patient with paroxysmal coughing than someone who's on ITU on a high dependency unit, who you're applying CPAP, or you're doing a sort of cough augmentation technique, not least because I think someone did ask about the risk to the front door people, and just to throw that into the mix, I think those people working in A&E probably see a greater volume of patients. People are more infective at the beginning. This is high flow nasal cannula. What is the risk around that? It's not just the device, it's the circumstances and the person.
That makes complete sense. Michelle, can I come in for you for some additional comments?
I agree with Anita. It's taking it in context. Very rarely do we just do one thing in alone. Often you'll measure someone's peak cough flow and then you'll go on to use mechanical insulation exfoliation. And so you'll be wearing high grade PPE in that instance. But if you do want to do a peak cough flow, look at, can you actually get the patient to do it themselves and be nowhere near them? It's a one-off intervention. So you can look at things from that perspective, and can they do it at home and feed back the result to you?
Thank you, Michelle.
And also just look, has that patient and their family been self-isolating and had no contact with the outside world, and you're visiting them?
Thank you. I hope that summarizes. It is a bit of a grey area, like everyone said, but hopefully there's still research going on into this, as Anita pointed out. And definitely sharing consensus, I think, is really important as expert groups. So thank you both for being with us today, and thanks to the other speakers. Paddy, I'm going to hand over to you to see if there's anything to wrap up.
No, I think, you know, I just want to thank everyone for taking time to speak. I know how busy everyone is. It is unfortunately only getting busier, particularly in the field in which we practice. And you know, as a testament to the importance of this area, you know, there were very nearly 500 delegates that signed up for this event. A number of people that have asked about whether this will be available afterwards, because they weren't able to stay for the whole of the time period, and so this will be available as for a limited period as a webcast as well, so people can pick up on that. And so thank you very much for everyone who's given us their time. It has for me been incredibly useful and interesting, and I hope it has for everyone else. As I say, please provide feedback, because that is vital for us all. And I really hope that things will allow us to see many of you in person for the summer meeting. But if not, we will, I'm sure, have another virtual foray to deliver for everyone. So thank you very much.
Thank you.
Thanks for organising.